Good morning, everyone. My name is Maya Luria with TMC for Seniors, and we are going to continue on with our Fall Prevention Month. Today, we're going to be talking about vestibular testing and is your world spinning? I have Haley Lanoue here with me. She is an audiologist with TMC Audiology, and she is going to share all about what she does as far as how you get that testing done and sort of what does it mean, right? This is another important piece to when somebody might be falling. So welcome, Haley. How are you today?
I'm doing well, thank you. How are you doing?
Good. So I'm going to go ahead. You do have an online audience along with an in-person audience today. So if you are watching from home, please go ahead. If you've got a question for Haley, put it in the chat for us. At the end, I will go ahead and ask her any questions that come in, and I'll let you get started.
All right, thank you so much. So, like Maya said, my name is Haley. I am one of the audiologists here at TMC, and I specialize or focus in vestibular evaluation, so vestibular testing. The Vestibular Imbalance Clinic at TMC is located in the Adult Outpatient Therapy Clinic. So that's where adult physical therapy and everything is. I do vestibular testing there, but then I also do hearing testing at the audiology office, which is in the atrium, which is in a different location. So kind of confusing, but I see both hearing tests and vestibular testing. Disclaimer, I am an audiologist. I'm not a medical doctor, and this is not medical advice. So we are going over the inner ear's involvement in dizziness. This is for education. So I do encourage you, if you're experiencing any of these symptoms, to seek medical care. So again, Vestibular Balance Clinic, we're at the Adult Outpatient Therapy Clinic. Vestibular audiology, the general kind of purpose of it is to evaluate the function of your inner ear portion called your vestibular system to help assess whether that inner ear is related to the dizziness, imbalance, vertigo that you are experiencing. So we're looking at to rule it in or rule it out as a part of your symptoms. Whereas physical therapy is going to do evaluation a little bit different than I would do, and then treatment to help overall reduce your dizziness, improve your balance, reduce your fall risk, and just improve overall quality of life as well. So they do diagnosis and treatment, whereas I'm more focused on diagnosis. And we work together. So we share patients. We're constantly talking to each other to help kind of get you the best specialized treatment plan that we can. So what is dizziness? Dizziness is a very broad term that can mean anything to anybody. It's what we consider an umbrella term. So it's kind of like you telling someone that you're dizzy is the same as just saying I'm sick to a doctor. It could mean anything. So I always like to start with going over kind of definitions of what dizziness is to help you describe your symptoms better. So one, vertigo is a symptom. It's not an etiology. So a lot of people will say they're diagnosed with vertigo. That's just a symptom. That just means you are experiencing a sensation of like spinning or swaying or tilting or essentially false motion when there's no motion. So that can be the room spinning or moving, or it can be yourself spinning or moving when you and the room are still. Whereas a disequilibrium is more of just like a general imbalance or unsteadiness. There's no room spinning or moving. Typically, that's worse with standing or with movement. Unsteadiness is feeling unstable. It can be standing, walking, seated. There's no like particular direction. It's not you're always falling one way. You're just kind of imbalanced. You don't feel sure of your footing. Oscillopsia is what people often describe as the world is kind of bobbing or moving or jerking. So you're walking and nothing is clear. Everything is just kind of bobbing up and down. Lightheadedness is feeling faint or like you might pass out or lose consciousness, what's called presyncope. So that's often associated with like standing up too quick and you get kind of those stars or black spots in your vision. You feel a little woozy. It doesn't have to be just standing up. And then dizziness, it does technically have the definition of the sensation of disturbed or impaired spatial orientation without a false or disordered sense of motion. It's basically everything else. So we like these other descriptors. I often ask my patients, can you describe your symptoms without using the word dizzy? Just because dizziness is so vague. I like these other descriptors, or if you just tell me exactly what you experience, you don't have to use all those fancy terms. That's for me to do. Other things that really help your provider get to know what's going on with you to help treat you best is telling not just what you're feeling, but telling the duration. So when did it start? Was it sudden or gradual? How often is it happening? Is it constantly there, or is it coming in episodes or spells or waves? Is there just one type of symptom that you feel? Are there multiple types of symptoms? Did one episode start and last for 3 weeks, and then everything else since then is different? Those are all really important to your diagnosis. A lot of diagnosing dizziness, especially of the inner ear, is what you tell the provider and the symptoms you're feeling, and then especially how long it's lasting, when it started, etc. Other important things are there any triggers? So can you provoke the dizziness by putting your head in a certain position, rolling over in bed? Does it happen with stress or with lack of sleep? Does it happen when you get worse allergies? Does it happen more when you're looking at a computer screen or if you're around a loud environment? Anything that you notice that's correlating with these episodes, I do recommend if you're having dizziness or anything, write down the episode, write down what you were doing right before then, where you were, things like that, to see if there's any patterns. And then any associated symptoms. So are you having a change in hearing? Is it in one or both ears? Are you hearing tinnitus, so ringing, buzzing, hissing, other sounds in your ear? Do you feel like a pressure or a fullness in your ear? Is it one or both sides? Are you having a headache, a migraine, any lighter sound sensitivity? Is there any weakness in your arms or legs? Are you having any changes in your face? So are you having like numbness, tingling, anything going on in your face? These are all important, and often more important than just telling me that you're dizzy. So who gets dizzy? About 15% of the population total has dizziness at some point. It increases significantly as we age. So over the age of 50, approximately 30 to 40% of people have dizziness, and it continues to increase as we get older, above 65, etc. It accounts for about 4% of all visits to an emergency room in the US. So 4% of every single person entering into an emergency room will come in with a top complaint of dizziness, vertigo, something along those lines. So a lot of people get dizzy, and there can be a lot of reasons for that. And why this is important is, one, you don't want to be dizzy, but two, it's a major risk factor for falls. If you're dizzy, you're much more likely to fall, break something, have poor outcomes. So we want to prevent falls at all costs. That's why we have this month, essentially. Of the 15%, so of all the people with dizziness, around 40% of those people have something going on with their inner ear. So that's what we are going to be talking about today, that inner ear vestibular function. About 10% of the people have central dizziness, so that's something going on in the brain, whether it be like a head injury, aging, it could even be something more serious like a stroke, things like that. 25% of people have medical dizziness, so that's like blood pressure related, cardiology related, change of medication or a side effect, those kind of things. And then around 25% of people with dizziness just don't have a diagnosis. So because there's so many potential causes, we are going to focus in on the vestibular system today. And I like to talk about the balance and vestibular system before we kind of go into the rest of everything. So your balance system in general is made up of three main parts and then your brain. So the three main parts are your vision, seeing the world around you, your vestibular system, that's your inner ear. It helps you to detect head motion and where you are relative to gravity. And then your proprioception, that's your touch and feel, feeling the ground underneath your legs, feeling the chair underneath you, all of that. And then your central system is your brain, puts all of that information together really fast all of the time. So the purpose of the vestibular system, that inner ear, is to detect head motion, so wherever your head is moving, and then to detect where you are relative to gravity, so where you are up and down, forward, backward, side to side. And the purpose of that system is it works with your eyes to stabilize your gaze, so every time your head moves, your eyes move because of your vestibular system. And it's why the world looks like it's staying still even though you are moving. It also helps you control your posture. It helps keep your head over your body. It helps you not fall over. It provides information about just where you are in space, and it just helps keep you upright. So to talk about the vestibular system, we have to talk about the ear. So there's three main parts of your ear, your outer, middle, and inner ear. Your outer ear is this part here. It goes from what you see on everyone's head to your ear canal to your eardrum. Your middle ear is this little space here. It's an air-filled chamber. There's three bones that help amplify sound down to your inner ear. So its purpose is to just amplify sound. And then it also connects to your sinuses through this tube here called your eustachian tube. That's why you get pressure in your ear when you're going up in an airplane, up in a mountain, or if you have a sinus infection. And then we have your inner ear. There's two main parts of your inner ear. One is this big spiral here. It's called your cochlea. That's your inner ear for hearing. So that's usually what we think of when we think of the ear. The sound travels from the outer through the middle down to this inner ear seashell cochlea. And then that sends a signal to the nerve to the brain for hearing. We're not focused on that one today, though. We are focused on the vestibular system, which are these little loops up here. This is a better picture of that vestibular system. Overall, your vestibular system, you have one on each side. It's paired together, and it acts as like an internal gyroscope for your head. So it's telling your head where you are moving in space, what way you're turning, and then where you are relative to gravity. It's filled with a special type of fluid that helps you detect all of that. So three of the parts of the vestibular system are called your semicircular canals. There are these loops here. So if you go back to this one, it's these loops here. These loops are called your semicircular canals. They're filled with a fluid, and every time your head moves, that fluid moves. So if you turn to the right, the fluid moves to the right, and that's how you know you're going to the right and the left, and it's constantly looking for symmetry between the two ears. So it's like a little teeter-totter in your ear, but in all directions for your head. And then we have what's called your otolith organs. They're little gel-like membranes, and they are coated in crystals. And those crystals help you detect gravity going up and down, forward, backward, side to side. So you have little crystals or rocks in your head that tell you where gravity is.
Rocks in your head.
Yeah. And then all of that information, so the loops and the gravity detectors, all of that gets sent to the vestibulocochlear nerve. So that's your cranial nerve that takes the information from your ear to your brain. It goes through centers of your brain called the cerebellum, which helps you with like your motor movement, and then it goes through your brain stem, and then it goes to your cerebral cortex to be processed. So your inner ear detects all of this information, sends it to the nerve, to the brain, to know where you are in space. And then it shares the same nerve with the cochlea, and that's why it's all part of the same inner ear. When we talk about your inner ear function, we usually break it up into peripheral and central. So peripheral is your senses. So it's your ear itself. It's also that first part of the nerve that it connects to. Your peripheral systems also include like your vision and then your touch as well. Your central system is once that information gets into the nerve, once it starts going, that's your central system. So it goes through your cerebellum, brainstem, connects with your eyes. All of that information is processed by your brain. And that's your central system. So we covered the ear. I know that was a lot, but essentially it's a gyroscope for your head, and it works with your vision and your touch and feel. So if you have dizziness, what do you do? Dizziness, vertigo, imbalance. I recommend first starting with your primary care doctor. So talking with them about your symptoms, because they are going to be able to triage, do they think it's a medical concern? Do they think maybe you need an emergency room visit? Or is it something going on with your heart or a medication change? So they are going to best see everything about you and triage where you go next. They might make any number of recommendations from there, including an ear, nose, and throat doctor, audiology, physical therapy, a neurologist, cardiologist, et cetera, et cetera. It's always very important when you are working with dizziness to work with an interdisciplinary team. So working with multiple providers to get information kind of from all areas of your life, especially when you're dealing with a possible inner ear cause. So audiology, what I do is I gather diagnostic information. I'm looking at the overall function of your ear, and that is going to get information so that the physician, the ear, nose, and throat, or the primary care neurologist can help come to a diagnosis of what's causing that. So they're looking at like the diagnosis, the medical cause, and they're going to manage it medically. And then physical therapy and occupational therapy are going to help improve your overall function, overall quality of life, help reduce your symptoms. So again, purpose of vestibular audiology is to evaluate the function of both the peripheral and the central vestibular system. We're trying to rule in or rule out that inner ear, and that really assists in diagnosis. So who might benefit from a vestibular evaluation, a vestibular audiology evaluation? My recommendations are generally people who have chronic, so constant or episodic coming and going, dizziness, vertigo, imbalance that's not responsive to current therapy or treatment. So if you're currently in physical therapy and after multiple visits it's not getting better, that's when I would recommend further diagnostic evaluation to help see what that underlying cause is so we can treat the right thing. If you have unexplained dizziness, vertigo, imbalance, nobody knows what's causing it. If you have a sudden onset of vertigo, first, if you like wake up and suddenly everything is spinning really intense and it's not going away for hours at a time, if it goes away in seconds to a minute, that's okay. You can go to your primary care doctor. But if it starts up and it's not going away all day, I would go to an emergency department to rule out a possible stroke, because they're going to be able to like immediately evaluate, do they think it's a stroke or not, get you the right treatment for that. Because that is a possibility. But once they've ruled all of that out, then see me so we can identify what exactly is causing that, and then we can get you in the right treatment plan. And then anyone with otologic symptoms, so that means symptoms related to their ear. Do you have hearing loss or tinnitus, ringing, buzzing, ear fullness, pressure with the dizziness, vertigo, or imbalance? That likely indicates something going on in the inner ear, which would then warrant vestibular testing. And then to rule out vestibular pathology. So if your doctor is just trying to rule out the vestibular system so that we can at least cross something off the list as what's causing your symptoms. So you've been referred for a vestibular test. What does that mean? There's multiple parts. We're always going to start with the case history because that is one of the most important things in all of understanding your dizziness, is understanding what's actually you're experiencing. And then we do not just what you're experiencing with your dizziness, but also your hearing history, your medical history, all sorts of different things. And we go over some questionnaires that just help guide us to the diagnosis. Then we're going to do an audiologic evaluation. So that's your hearing test. We always do a hearing test with the vestibular testing because they are connected, and different patterns of hearing loss can either impact what we see on the vestibular testing, or it can help lead us to the right diagnosis. So we always do a hearing test. We're looking at how well you're hearing. Then we're also looking to see how that inner ear is working compared to the outer and middle ear. So is there an ear infection going on? Is there fluid behind your ear? Things like that. And then we are going to do the rest of this testing. So one of them is called VNG, or video nystagmography. Oh, I just went over that. So VNG, video nystagmography, we are putting some really big goggles on you, and sometimes they're completely closed off so you can't see anything, and sometimes they're open so you can see something on a screen or like a TV in front of you. And I'm looking at your eye movements. Because your eyes and your ears are connected, we can use what your eyes are doing to tell us what the inner ear is doing. So we're going to be looking at just how well your eyes are moving on their own without any head movements, without anything from the inner ear. Then we're going to be moving your head in different positions and laying you down in different positions to get information about what happens with your inner ear when we lay you down. Is there something called BPPV, which is crystals in your inner ear out of place? I'll go over that a bit later. And then we are also just looking at, is that vestibular system responding? When I move your head quickly, is it responding? Am I seeing any kind of imbalance between your ears? Or are both working or are both not working? Part of that VNG test is called the caloric test. So this is where we either put warm and cool water or air into your ear canals. We do water here at TMC. But the idea is when we put water into your inner ear, or not into your inner ear, we put water into your ear canal, it hits your eardrum, it comes right back out into a little bucket, and it makes your ear either warmer or cooler than your body temperature. And because we do that, because we change the temperature, it affects the fluid that's in your inner ear, and it tricks your brain into thinking like you're spinning. What's nice about this test is we can compare the ears together. We can say, are they both working? Are they both not working? Or is one working better than the other one? And we're able to do that without moving your head. Every time we move your head, we're looking at both ears at the same time. With the water test, we can identify one ear from the other so that we can compare them to each other. When we put that water in your ear, I'm looking at an eye response called a nystagmus. So your eyes are moving rapidly back and forth like this, or like this. What you feel is you feel like you stepped onto a tilt-a-whirl at an amusement park. So you feel like you are spinning. It gets more intense and then it comes back down. The nice thing about this test is it's a controlled spinning. So even if you've had vertigo in the past and you felt that room spinning, it's not quite the same because we're making it happen. We know what's causing it to happen, and we know it will end once your ear comes back to body temperature when that ear is out. The whole process takes about 2.5 minutes for each side. So we do warm water in each ear and then cool water in each ear. It's not the most fun test, but just think as if you're going on a roller coaster. Your grandkid dragged you up on that roller coaster. Then we also do something called VEMP testing, vestibular evoked myogenic potentials. This is an evaluation where I put little stickers or electrodes on your head, your neck, underneath your eyes, and then I play a loud sound that sounds like a clicking sound, like a or like someone is like banging on a doorway in your ear. And that gives us a response from those little gravity detectors so that we can compare those gravity detectors to each other. So we're looking at both of the gravity detectors there and then looking for symmetry, presence, absence, all that good stuff. And then if we go back to the caloric test is looking at those canals, how the canals are functioning, whereas the VEMP test is looking at the gravity detectors. So now we have information from both parts of that inner ear vestibular system. Then we also have VHIT testing, or video head impulse testing. This is looking at the information from those canals again. So remember the ones that tell you where your head is moving. It's connected directly to your eyes. So what I do is I place some goggles on you, and I am moving your head quickly back and forth like this. And I'm trying to see, can your eyes stay on a target in front of you? Or when we move your head, do your eyes move with your head and then have to catch back up to the target? And that tells me how those canals are working. So I'm essentially just standing behind you and moving your head back and forth like this. And with all of that information, we're able to get information on how each of the 5 parts of that vestibular system are functioning. We're also getting information on how your eyes are moving. So we're looking at some of those central connections with your vision as well. We're looking for presence or absence of function. We're looking for symmetry. We're looking, is it your inner ear or is it central or something else going on? Those results help us kind of put together pieces of a puzzle with your history to help lead us to a diagnosis. So my information, I'm looking at how well your ear is functioning, kind of like how well you're hearing on a hearing test. And then that information gets sent back over to the ear, nose, and throat doctor or whatever physician sent you to me, and that helps lead them to the diagnosis. So they ultimately make the medical diagnosis, but I'm looking at the overall function of your ear. And then my information also can go to your physical therapist, especially if you're here at TMC, so that they can form their treatment plan for you. They're going to treat exactly what is not functioning so that you can get better the fastest. We're not going to just treat everything in hopes that something catches. We now have specific information about what's working and what's not working so that you get an individualized plan. And then I will also likely recommend other referrals or evaluations based on my results. So it might just be physical therapy and follow up with primary care, ENT, whoever sent you. Or I might see something that says there's something central going on, and I might say you should get a neurology referral. Or I might say these symptoms sound more like they could be your heart and there wasn't anything going on with your ear today, so you should see a cardiologist. So it really helps just kind of guide your evaluation and therefore treatment process. And then vestibular rehabilitation, so physical therapy, again, the diagnostic information really helps them with their treatment plan. And the whole goal is to improve dizziness, regain, improve, and manage your balance function. The ultimate goal is to make you not dizzy so that you don't fall. So we're preventing falls, and then we're also giving you your quality of life and your function back. We're trying to get you to be able to participate in this world as much as you possibly can in the safest way possible. Both audiology and physical therapy, we're also there to educate you on what's going on. A lot of this is confusing, and a lot of it, an ear, nose, and throat doctor doesn't have as much time as an audiologist does to talk to you about your symptoms and give you that information. Understanding what's causing it can be really empowering and helpful into knowing what's going on and managing your symptoms. And physical therapy does that as well. With physical therapy, just like any therapy, consistency is key. It's rarely a one and done. On occasion, it is one and done. I'll talk about that in a minute. But it rarely is a one and done. It's something that you are going to have to be working on every day for a long while. We recommend just keeping up those exercises moving forward, probably for the rest of your life. Maybe not to the extent that you were doing them in physical therapy, but keeping up with different head movements, keeping your balance as good as possible for the remainder of your life. So again, about 15% of the population has dizziness. About 40% of that dizziness has to do with the inner ear. What is causing that? What kind of things can go on in the inner ear? There's hundreds. We don't have time to talk about all of them. I'll take you to grad school with me, then we can talk about all of them. But there are a top 4 that we like to talk about because these are the 4 main inner ear related disorders that cause dizziness and imbalance in adults. So the first one is BPPV. It stands for benign positional paroxysmal vertigo. Benign means it's not life-threatening. Paroxysmal means it comes in sudden, brief episodes. Typically an event lasts a minute or less. Positional, it means it's triggered by a certain head position. So like rolling over in bed, getting up out of bed, looking up or washing your hair in the shower. Quick head turns, like as if you were checking your blind spot in your car, things like that. And then vertigo means the false sense of rotational movement, so usually spinning vertigo. What's happening is if you've heard of the crystals being loose or something out of place in your ear, those crystals, the otoconia, come loose from the little gravity detectors where they're stuck. So they normally just help you detect gravity. They can come loose and they can go into the canals where that fluid is, and they swim around in those canals. And every time your head moves, that little crystal moves, and it moves the fluid more than everything else in your brain expected. And it causes you to spin until that crystal settles down again. And then when you move again, it spins until it settles down again. It's the most common cause of dizziness in vertigo. It accounts for about 50% of dizziness in all patients. It occurs in about 2.4% of people. It's significantly more common as you age. So above the age of 65, it increases in likelihood. Who's most affected? People over 65, head trauma. So if you bang your head, you can cause those crystals to come loose. People with migraine are more predisposed to have BPPV. Any kind of inner ear infection, we'll talk about one type in a minute, can cause you to have BPPV later on in life. Diabetes, osteoporosis, reduced blood flow, low vitamin D levels, low vitamin B levels are also some factors as well. But the main one is aging, and we can't stop aging. So what's nice about BPPV is it can be quickly tested and it can be treated as well. We test it by laying you down in different head positions. So we're trying to provoke that dizziness, which is usually what you don't want to do when you're home alone, but when you do it with a provider, it's okay. We're making you dizzy for a purpose. We have to make you dizzy to know what's causing the dizziness. And then we make you dizzy. We're looking at different eye movements. There's a certain pattern of eye movements we're looking for that tells us, is it BPPV? And then what area of the ear it's in. And then we can move your head around in different positions. So the most common one is the Epley maneuver. You lay down and we rotate your head in different positions, and then you lay down your side and sit up. And that causes the crystal to fall back into the gravity detector area, so back into place, so it's not swimming where it's supposed to be. Sometimes that's a one and done. You have one episode, you get it fixed with a physical therapist, and it's done. About 50% of people with BPPV will have it reoccur at some point in their life of varying frequency. Another common cause is something called Meniere's disease. For the rest of these, they're a bit complex. I'm going to go through the main bullet points just for timing's sake. But Meniere's disease is typically people who have fluctuating episodes. They have all of a sudden vertigo that starts out of nowhere. It wasn't head movement triggered. It lasts from minutes to hours. And then you usually get some kind of fullness, pressure, ringing, or hearing loss in the ear that's affected either before, during, or after that vertigo attack. It typically comes on more frequent episodes at first, and then it falls into just more of a general loss of function on that side. It affects 15 out of 100,000 people. It's most common in ages 40 to 60, and it's typically progressive and it fluctuates. So you can go months without anything, years without anything, and then all of a sudden you have multiple episodes in a row, things like that. Then we have vestibular neuritis labyrinthitis. This is a type of inner ear infection. So it's typically a viral infection. Sometimes you can have some kind of cold, flu-like symptoms leading up to the onset of this. Sometimes you don't have anything. And it's just an infection in that nerve that connects to the inner ear. These are the people who have all of a sudden really sudden room spinning vertigo that lasts for a full day up to 3 days at a time, and it just never stops. And you're sitting there and everything is spinning, people can see your eyes moving, and then it gradually gets better over that first 3 days is the worst. The first few weeks, it's getting better, but you're pretty imbalanced and dizzy with head movements. And then typically in about 3 months, you're recovered. Not always the case, but that is one of the top causes of inner ear vertigo. Most common in ages 30 to 60, but it can happen to anyone. If you are having that severe vertigo lasting all day, I do recommend seeking emergency evaluation to rule out a stroke or anything else that might be causing that. And then one of the last ones we're going to talk about today is vestibular migraine. Vestibular migraine is a type of migraine. So you usually think of migraine with people with like a really severe throbbing, pounding headache. About a third of people don't actually experience any kind of headache with vestibular migraine, or at least during their vertigo attacks. But you can have vertigo lasting from minutes to hours to days at a time. And it can be room spinning, it can be a rocking, floating sensation, it can be just motion sickness, nausea, it can be literally anything. And it comes and goes. About 50% of the episodes will typically have a headache associated. Most people have some kind of history of headache or migraine in their lifetime before that, or some kind of family history. It is more common in women or females. It's more common in people who are age 30 to 60, but it can happen at any time of life. And again, it can happen even without a headache. And treatment is generally treating the underlying migraine first. Physical therapy can be really helpful, but once you're not in an active migraine state, if you're in a migraine, you're likely just going to trigger more symptoms. But once you're able to be out of that migraine for a little bit, physical therapy can work on your overall function to make you less sensitive to movement and things like that. So those are just the top 4 ones we're talking about today. There are some resources for you. I highlighted this first one, Veda Vestibular Disorders Association. They have a really great website of a ton of resources for patients, including going over all of symptoms of dizziness, causes of dizziness, what the inner ear is, what to do if you are having dizziness, patient stories, all sorts of things. So I highly recommend them if you want to be looking up more information online, but there's a couple other associations as well. And then to schedule with Vestibular Imbalance Clinic, we do at TMC require a physician referral. So even if your insurance does not require a referral, we still require a referral to be seen here. And so you get a referral for vestibular audiology or physical therapy or both. Make sure you're getting referred for dizziness, vertigo, something along those lines, so that we can see that that's what you're here for and get you to the right people. Referrals are faxed from your provider's office to this number here. We're located on just south of Grant from the emergency department. And then you can call either of these phone numbers to get more information or check on a referral if you think you have one in, etc. So that was a lot of information I threw at you. You guys are all experts in the vestibular system now.
So thank you, Haley. I do have some questions that came in that I wanted to ask before we turn it over to your in-person audience. Does low blood pressure contribute to vertigo?
It can. Low blood pressure typically causes lightheadedness or like kind of a swimmy sensation, but it can also cause spinning vertigo as well.
Okay. And can hearing loss be related to vertigo?
Very much yes.
Okay.
Because they're both in the inner ear. There's many things in your inner ear that cause hearing loss and vertigo at the same time. You can also have just hearing loss or just vertigo.
Okay. What about the buildup of earwax?
Does the buildup of earwax cause vertigo? Not typically. It can cause like a fullness, pressure, rarely it can cause dizziness, but your primary care provider can look for that. Audiology, we always check for earwax first before we do anything else.
Okay. And are there any kind of preventative measures that can be taken to avoid having vestibular issues down the road?
Are there any preventative measures to avoid vestibular issues? Not necessarily. There are some links with vitamin D and vitamin B levels, so making sure your vitamins are in order. Staying active is important. The less you move your vestibular system, the less you use it. And then if you don't use it, you lose it, right? So it's just kind of like a muscle like anything else. So staying active, even if you aren't able to physically get up, keep looking around, moving your head up and down, side to side, can be really helpful for just making sure you're using your vestibular system as much as possible. But unfortunately, a lot of vestibular issues just kind of happen. They can happen with age. They can happen because they're associated with diabetes, high blood pressure, things like that. So just generally taking care of your health. But if you get vertigo, it's not like you necessarily caused the vertigo.
Okay. Now, when somebody is coming in for testing, how long is that process typically? Like, what does that look like when they come to the clinic?
So how long does the testing take? So the hearing test portion we typically do first. That is about an hour-long appointment here. We do the history, the hearing test, all that good stuff. We make sure your ear is free of earwax, you're not having an infection, something like that. And then the vestibular test portion, we schedule you for 3 hours. Sometimes it takes that whole time. Sometimes it takes closer to 2 hours. It depends, but up to 3 hours.
Okay.
It is long.
I want to go ahead and just put up the phone number again for anyone who might be interested in an appointment. Again, it does require a referral, but the number is 520-324-7005. I want to thank you again for being here, Haley. I'm going to go ahead and wrap up with our online audience, and I'll turn it over to you to do any in-person questions. So thank you.
Thank you, Maya.
Thanks so much for being here again today. We look forward to seeing you again next week. We will be doing Independence and Aging, Myths and Facts on Tuesday, September 10th at 10 a.m. I also have Unsteady Ground, Navigating Balance Concerns. That is on Wednesday, September 11th at 10 a.m. If you're interested in any of these classes or any of the upcoming fall prevention classes, you can always give us a call at 520-324-1960. Have a great day.